Gite sir, good evening. Gaurang Shah sir, good evening.
Yeah, good evening. Good evening. We wait for some time. Little.
Yes,
because
sir.
today now, today we by mistake we gave the link little late. So
Okay.
the students may not join immediately. They may take 5-10 minutes, but it's okay.
Okay.
So we'll just start in another 5-10 minutes.
ठीक sir. Okay. Okay.
Make Dr. Hudedar co-host. Who are answering today?
So Ojas here, sir.
Pardon?
So Ojas Poddar, sir. Kokilavan Hospitals.
Okay. Ojas say that. Good.
Yes, sir.
Once Dr. Ganesh Bakshi joins, we just start.
Yes, sir.
I think it is 9:15. We start. Dr. Ganesh will join.
Okay, sir.
Dr. Gite?
Yes,
Dr.
sir.
Gite is there.
Yes,
Sir,
sir.
I think we should start now.
Number is slightly less, but we should start.
We start now. So, and Dr. Ganesh and others they will join later. No problem.
Okay, sir.
Mahendra, you are there?
Yes, sir.
Okay. Okay, then fine. Okay, we are starting.
Yes, sir.
Paras?
Yes, yes, sir. Hello. Hello. So last time we discussed the case of painless complete hematuria, which on ultrasonography had a polypoidal growth. Confirmed with CT, TURBT was done, and it comes out to be non-muscle invasive bladder cancer. So this time scenario 2. Dr. OJ.
Yes.
So this is a case of a 58-year-old gentleman shopkeeper resident of Mumbai presented as a known case of urothelial carcinoma diagnosed post URBT. The patient was apparently asymptomatic 1 month back when he started having on and off blood in urine. This is the history prior to the surgery. Uh, the uh, the blood in urine was sudden in onset, painless, complete, progressive, and was associated with passage of amorphous clot. For this complaint, patient underwent a TURBT. The report of histopathology is attached. Microscopic section was shows high-grade papillary epithelial carcinoma with lamina propria and deep muscle invasion.
Okay.
So, just what do you want to know?
What was the size of the lesion? I would like to know what was the USG before that. What was the size of the lesion before that? And whether before the TRBT, any other imaging was done apart from this? What was just the USG was done, or
No, a
anything
CT
else was
scan
done?
CT
Sorry.
scan was also done.
Okay. Um,
No. Before that, always
yes, sir.
you have to examine the patient. The patient will come to you with the this pathology report and the history. Okay.
Yes, sir.
I think Gita sir will agree with me that in examination, even you have this report without in examination of the patient, don't jump on investigation directly, right, sir?
Yes, yes. Because you have only a muscle positive shea bladder as per the histopathology. So we have to check the patient physics, that is performance status, then clinical examination. Then you have to ask report about the stage of the tube because it is histology only. So local stage के लिए कुछ investigations हो चुके हैं क्या? Metastatic evaluation कुछ हो चुका है क्या? ये सब चीजें पूछना पड़ेगा. तो पहले patient examination is also important as well as stage and
Yes.
metastatic evaluation. Any investigation they have done prior, that you have to ask so that you can plan the treatment.
Exam don't forget this sequence. Okay.
Okay. Yes, sir.
Whatever presentation has been given to you, okay. If already they mention the examination, then they're a different thing. But if it's not given, always after history, go for the examination.
Yes, sir. So I would like to ask initially that in the 1 month, whether the patient is how is the urine, whether there is still persistent hematuria, whether
No,
he's
I
having
think
any.
just that we have covered in last case. Okay.
Okay. Okay.
So let's don't go into this thing, basic things in the history, like past history, occupational history that already there. Okay. So now the patient has come with this report and the pathology report. Okay.
Yes, sir.
So now how will you proceed?
I would like to know whether the initial imaging. So I would like to know about whether staging investigation was done. So we on a histopathology, I can see it's high grade and muscle invasive, but I want to know the local and the distance staging. So whether any imaging was done beforehand, if that any reports available, or if not done, then I would uh, like to do an imaging first to know the local staging of the tumors.
Okay, fine. So just want to clear one thing. We are not discussing the history, the basic part, because already has been discussed in the last case. But if you
Yes, sir.
if you get this case in the examination, you have to ask all those questions.
Yes, sir.
Okay, we are
Yes.
skipping that part because that again will take half an hour for discussion that already has been done.
Yes,
Okay,
sir.
yeah.
Yes, sir.
So don't get confused कि नहीं हमारी क्लास में ऐसा बोला गया था कि we can escape, we can just jump to that is the other investigations. It's not like that. Okay.
Yes, sir.
Okay. So what do you think with the pathology report? Suppose that before going to jumping to the investigation, what do you think what it can be?
So it might be
Anything is missing in the pathology report or something you want to know something about the pathologist? Anything or something else?
No, sorry. They mentioned about lamina propria. They mentioned about the the grade, and they mentioned about muscle.
Mhm.
So they have mentioned most of the things. So they have mentioned everything, sir.
Are you sure?
Uh,
What about LBI?
yeah. Okay, sir.
What about
Lymphovascular invasion.
what about variant? What about the variant thing? See, I did not ask about this patient. I asked about, my question was, what else you want to know, or you should see in the pathology report.
Uh, so apart from the points which have been mentioned about the grade, lamina propria, and deep muscle invasion, mention should be about the lymphomascular invasion and if any variants. So if any high risk variants are seen in the histopathology, so that should be mentioned in a histopathology.
Okay, fine. Okay, Paras.
Mahendra, you want to add anything? You think anything is important for the exam point of view?
No, sir. As the case has presented like this, I think that is the flow only, because once suppose that it is a pathology shows some high risk variant like macropapillary on some plasmacytoid variant, right? So again, the things will be going a different way. But let's go, sir, in this general thing like that, a high grade UCC with that's muscle invasion. So it will go to our conventional UCC, not the some variant where the treatment is still straightforward.
Okay, fine. Paras, go ahead.
So this is the negative history. There's no history of
Okay, that is.
headache.
I think that we can skip that.
Ojas,
Only positive.
Yes, sir.
if this patient histopathology report has not from your place, then do you want to review the slide with your own pathologist or you don't want?
Sir, I will review to know if any high risk variants are there. Apart from that, it has mentioned about the muscle invasion and the lamina propria invasion, and it has mentioned that there is muscle in the histopath scene. So this case, uh, I would like to I may review if I want to know about any high risk variants are there. Apart from that, the report seems to be complete, sir.
So what are the variants? Sir has told one or two, you can complete the list.
So the variants are the high risk variants are plasmacytoid variant, lymphocytoid variant, squamous variant, and sarcomatoid variant, and nested cell type. These are the high risk variants with aggressive pathology.
You missed
Any other?
one more common. You missed that. That is more common than nested and plasmacytoid variant.
Any other?
So
That's what. Any other?
lymphocytic.
Any other?
Adeno. That is adeno only. So this
Okay.
I know, sir. Nested cell. Yes, sir.
Micropapillary is
Okay,
one of the,
yes.
and neuroendocrine.
Okay, yes.
Okay.
So in the comorbidities, patient is diabetic and is on oral hypoglycemic drug. In personal history, patient is a known smoker. Back per year is 30, and smoking index is 600, not 400. It's 600. The general examination, patient build is normal. All the general examination parameters are grossly normal. On per abdomen examination, there is grade 2 prostate enlargement, firm, non-tender with mobile vector mucosa. Patient is circumcised. Rest all is normal.
What was the Karnowski performance score?
600.
100. Okay.
Okay, now what are the investigations you want to know from him?
So I would like to I would ask for a CT contrast enhanced CT scan abdomen plus pelvis after knowing the creatinine value with preferably a CT chest for the staging of the tumors.
So one common question will be in this scenario, will you ask USG, sonography abdominopelvis, or directly CT scan?
Sir, this patient has undergone a TURBT and it is showing high grade. So for a detailed staging, I would like to do a CT scan. So directly go ahead with the CT scans, which will include even chest.
In spite of telling like that, sir, probably majority of the patient came with already ultrasound in their hand. And as an extension of clinical examination, if it is not done, I will be happy with doing the USG report also, which will give a primary basic information about the pathology, the ascites, some metastasis in the liver. This can be defended. So as a already 100% patient sonography के साथ ही आता है.
Yes, sir.
समझ गए ना? तो नहीं करने का और डायरेक्ट सिटी स्कैन में जाने का है तो फिर अननेसेसरी ट्रबल में जाएगा ना. तो ऐसा बोल सकते कि usually majority patient came with sonography report only, sir, and already this patient have underwent TURBT, so he may already have a sonography report with him. And if at all if this patient come first time to me with this report with muscle positivity, now here you can avoid the sonography because already there is a muscle positive, and we have to assess the performance status of the patient, local staging of the patient, and metastasis. These are the three factors before going before these are the three factors to check the feasibility of the removing the bladder.
Yes.
Right, Ojas? Sir, absolutely,
Yes,
sir.
sir.
Describe very well. Okay.
Yes, sir.
So in a little bit more scientific, I'll just have to add, as we know this is a muscle invasive bladder cancer. Now we have to stage the disease, and CT scan is the investigation of choice for the staging in the bladder cancer. Right?
Yes.
This is how
Yes,
you can escape this question ki, whether you will do USG or not, because in sonography you cannot differentiate 100% it is a T3 or T2 disease or maybe T1 disease. Okay.
As in last case, we have discussed like there is a role of CT. So here, if the patient is muscle invasive, then there is definitely a role of CT, and all guidelines recommend the CT scan. So you cannot escape the CT scan in this situation, as like in last case.
Yes.
And always when you put investigations, I think you should just learn one line: routine investigations along with the RFT. I will do that.
Agree.
Yes, sir.
Okay. Don't see only the serum creatinine because maybe his hemoglobin is 5.
Yes, sir.
Okay.
Yeah. Yes.
And now again, a very important question in this case: what about urine cytology? Will you do in this case or not? If yes,
so yes, sir, I
why?
will do a urine
If no,
cytology
why?
in this case. Yes, sir. So because it will be a baseline. Initially, the patient did not have cytology. It's come as a high grade, so it will be used as a baseline to assess further follow-up, sir. So I will do a urine cytology and a CT scan, abdomen plus pelvis with contrast along with chest, and routine investigation, which include complete blood count, serum creatinine, serum electrolyte, and a urine routine and a urine culture.
So what benefit you are getting by doing urine cytology in this case, where you already have biopsy proven it is a high grade cancer?
So it will be used for a follow-up, sir, and basically for the follow-ups, it will be used for as a part of follow-up. This will be baseline. So if in this case we get a positive cytology, so then or if we get a negative, and then if we get a positive in the further cases, then it will be used as a for a follow-up thing, sir.
So now this is the tendency of students ki if they said any line or any word, they want to defend it. Okay. And when you defend it, is it wrong? Is it wrong actually at this scenario? And you are just going toward the something is non-specific things. How cytology is useful for a follow-up or any prognostic thing? Tell me. In initial evaluation, the role of cytology is that it will do high grade or low grade disease. Okay.
Yes.
Whether you
Yes,
should
sir.
do further investigations or not. When already you have biopsy proven high grade disease, okay, and anyway you are going to do a CT scan at this stage, there is no benefit of doing cytology.
Suppose your urine cytology came negative. Are you going? Is this going to change your plan?
No, sir. It's not going to change the plan. It will be. I was just saying it as a baseline thing to know. That's it, sir.
So why usually? What is the indication of or purpose of doing the urine cytology?
So to distinguish it in low grade and high grade. So in the
Already
high
you have
grade,
report. Already you have report in your hand, which is suggestive
high
of high
grade,
grade.
high grade. Yes, sir. So, okay, so then we'll do only on the follow up, sir. Only on the
So
follow up. Later on,
why
we'll do it. No.
why did I raise this question?
Yes, sir.
Only to you people to learn one thing. Is it not like mathematical thing? You always you have to do set investigation. Whatever however patient presents with. Okay, you have to individualize the scenario and do as per the need. Okay, it is your
Yes.
responsibility, broad your responsibility, not to over investigate or not to under investigate of the patient. Okay, this is all up to you.
Yes.
Yeah. Right, Gita sir?
Yes, sir. Yes, sir.
Okay, fine. So what we have now, Paras?
Paras,
Yes, sir. So urine routine microscopy, pH is 6.5. RBCs are 2 to 3 per high power feed. WBC is 0 to 2 per high power feed. No growth seen on culture. Urine is negative for atypical and malignant.
Okay. Just
The blood test, hemoglobin is 12, creatinine is 0.72. It's all normal.
Okay. So scans.
This scan is before TURBT.
This is before TURBT. Okay.
Can we zoom it? So or just can see that.
Uh,
Yeah.
so this is a contrast enhanced CT scan of the abdomen plus pelvis plus chest. The chest appears normal. The liver appears normal. There is no ascites. Bilateral kidneys and spleen also appears normal. The bladder is distended. In the bladder, in the contrast films on the right and right lateral wall, there is a growth enhancing lesion seen over the right lateral wall. Over the right lateral wall and also near the right ureteric orifice, which is enhancing. There is no any bilateral kidney is normal. There is no. Yes, sir. So this is suggestive and perivesical. Um, there is some perivesical strand, fat stranding seen. This is the fat case not maintained.
Yeah. Okay.
Near the side of the lesion.
Okay. So just like a cystoscopy, when you describe the lesion in CT scan, it should mention about papillary, sessile, okay, and the numbers. And what if you see it is reaching up to right PUJ in some plane, but majority of the mass is right lateral wall.
Yes, sir.
That means it indicates that you do not know at what part of the bladder right ureter actually the course of right ureter or any ureter. It is quite away from the right ureter actually.
Yes, sir.
And for me, telling about T3 disease, T3A, this imaging is not very easy because the wall of bladder is very smooth. Okay, it can be T2 but not T3. Maybe other image can be, but whatever I have seen in not in those images. Okay, maybe this image. I can you go back to the previous one? This one, the second one, second left. No, not this one. The sagittal plane. We have sagittal coronal. Not axial. Yeah. If you see the middle left second one.
Yes, sir.
So if you see the normal, the bladder is like a balloon shape structure, and if any part is going beyond that the course of the wall, just like I think in the second film, the left side, the center, second, first and second, the bladder is going beyond the bladder wall tumor. You see the first image, left side, first image, left side, first image. The central, yeah, it is going. It is a T3 disease, right?
Yes, sir. It is T3. Looks like T3. The perimeter planes seem to be disturbed, sir. They're not cannot be clearly defined.
Okay, fine. So you should suppose that if you have a doubt, so any role of MRI?
So MRI could be done if there is allergy to contrast, and or if there is creatinine values high, then we can do an MRI urography. Yes, sir. This would be the two indications for MRIs.
Okay. What other indications for MRI in bladder cancer?
So when
last time we discussed about something a little bit about the virads.
Yes, sir. Yes, sir. It could be yes, sir. In virad scoring is used to distinguish whether preoperatively whether it is muscle invasive or non-muscle invasive, in which it is a scoring based system in which a higher score would suggest more likely to be a muscle invasive, which would help to preoperatively plan the better line of management for the patient. Sir. So it can be used as a staging for distinguishing between muscle invasive and non-muscle invasive.
Yeah, whether is a primary or is a follow. Basically, it roll in the follow-up cases where
Yes,
follow-up recurrence is there, where is it to do a TURBT or not. Okay.
Yes, sir. Yes.
Okay, fine. Okay.
Paras, just read the report and let's go ahead.
On CT, there is a heterogeneously enhancing polypoidal mass lesion on the right lateral wall of the urinary bladder. It is about 56 into 22 millimeter along the axial dimension and 55 millimeter in the craniocordial dimension. Mild nodularity on the bladder surface is seen. No perivesical fat standing.
Okay. No perivesical. This case is a T2. Okay.
Yes, Ojit. So now, next, what you want to do?
So first, also, I would like to know what was done in the TURBT part, whether the tumor was resected entirely. What was there in the TURBT? I would like to know as any operative findings if available, sir.
Tumor was resected entirely.
Entirely. Okay. So based on the CT scan report, appears to be muscle invasive. So it appears to be T2B lesion, T2B N0M0, because there is no fat standing. So this patient has to be first counseled that this is a high grade lesion, but it is muscle. So patient has to be counseled about the different treatment options available. Now the patient has could be we counsel him that he will require further treatment. Now it has to be discussed with the patient that the treatment could be in the form of surgery, or it could be other, there are other modalities of treatment for the same, which could include neoadjuvant
So
chemotherapy. Then, yes, sir.
listen, patient should be consulted for need, type, and risk of surgery, about
Yes, sir.
multidisciplinary approach, risk and benefit of neoadjuvant chemotherapy, pathology required, as well as radical cystectomy, should be concealed for possible all forms of diversion and expected life changes post-operatively, of complication of radical cystectomy as well as conduit, all things operative and post-operative complications. So counseling
Yes,
should be thorough and patient related. ये सब वन
yes, sir.
प्रॉपरली आना चाहिए क्योंकि काउंसिल वो आस के आ गए तो उसमें एक आस के रहता है काउंसलिंग पे.
Yes, sir.
Yeah, Ganesh
So,
Bakshi has joined. So Ganesh, you please,
No, sir.
tell him if
Sorry,
anything
I
is
had to
required.
join late. थोड़ा सा late हुआ sir. Sorry.
No problem. So any comment till now, whatever you have heard?
नहीं sir. I was hearing what Gite sir was saying. इसके बाद ये कर.
Okay, fine. Okay, Ojas, go ahead.
yes, sir. So the patient would be counseled in front of a multidisciplinary team regarding the different treatment options available. What are the risk and benefits of the same, and what are the complications associated with every treatment modality.
Oh,
The
yes.
patient has
Sorry
to.
to
Yes, sir.
sorry to interrupt you. But
Yes, sir.
first of all, you have to tell the patient what is he suffering from,
Yes.
Correct.
right? You
Yes, sir.
cannot directly jump to कि नहीं आपका ब्लैडर निकालना पड़ेगा, आपको कीमो देनी पड़ेगी. वो बोलेगा क्यों? Why?
Agreed.
Okay, you have to
Yes,
explain the patient कि as per the biopsy report, as per the CT scan, you are having the bladder cancer, which is involving the muscle and going beyond the muscle. So it is like stage 2 and 3 disease. Okay.
yes,
So you have to say about the good and bad part. That good part that it has not gone beyond the bladder, nodes are not involved. Okay. You had आपको ये नहीं कि you are making him scared कि he is having cancer. You have to build confidence in him. कि even
Yes.
he is having cancer, okay, there is a treatment and he can be cured.
Yes, sir.
So that is the part of counseling, okay, to build confidence in the patient, because already when he read the biopsy report, there is a high grade cancer, okay, he will be in depression after that.
Yes, sir.
Okay.
So yes, sir. The patient would be explained first about the diagnosis, that it is that he has a bladder cancer and that it is involving the muscle. However, there is no local advancement or there are no any distant metastasis. The patient would be then discussed and the relative will be discussed in front of a multidisciplinary team regarding the various treatment modalities available for the treatment of the same, which would include surgery and a neoadjuvant chemotherapy followed by surgery, and then the patient would be counseled about the risk and benefits and complications should be the same. The patient would be uh, uh, counseled that in part of the surgery, as the it is involving the muscle, he would require if we go for the surgical option, he would require removal of the entire bladder, and then it has to be discussed uh, whether he desires continence, whether he uh, to discuss for a neo bladder, or whether he's how is the status at his home, whether he is able to take care of himself, whether he desires a continent bladder or he is okay with an annual conduit. Uh, the other option available is a neoadjuvant chemotherapy, which has to be discussed, which has to be explained that this is a uh, therapy which would require further surgery followed by the chemotherapy, and the risk associated with the chemotherapy, and has to be explained. Yes, sir.
What will be the specific sequence in this patient?
So in this patient, sir, patient could be since the patient has a good Karnofsky performance score of 100 and the creatinine is normal and it is muscle invasive, we can offer radical cystectomy with an ideal condio or a neobladder, depending on what the patient desires and his status at home, whether he will be able to take care of himself to empty a continent bladder.
So what about T3B disease? What guidelines says at present about T3B disease?
T3B disease would be first to give a neoadjuvant chemotherapy, followed by consolidation surgery.
So despite of knowing the guidelines, why you are deviating yourself from the guidelines?
So CT scan is saying there is no perivesical fat standing. So in the films we were not very sure about the.
You have seen that. You have seen
Yes,
that
sir.
tumor
Yes, sir.
tumor is going beyond the bladder wall.
Okay, so based on that film, sir, it seems to be T3B, but okay, sir. Then we'll offer a neoadjuvant chemotherapy first, followed
So you
by
should understand. It is not like that. I am.
Yes, sir.
Is it not like that? I am saying that you will this thing change your decision. Okay, you should understand that. So it's what you can say that I can take second opinion about the CT scan from the one expert senior radiologist about that thing, about the T3A, T3B disease. Okay, then I take a call about the neoadjuvant or the upfront surgery.
Yes, sir.
Okay. So, chalo, we are going giving neoadjuvant chemotherapy. So, what chemotherapy you will offer to this patient?
So there are the different options available as a dose dense MVAC therapy or gemcitabine cisplatin based on the creatinine clearance. Dose dense MVAC is given for initially would be 6 cycles along with growth factors, or the other option is gemcitabine cisplatin if the creatinine clearance is normal.
Okay, which is better?
If the creatinine clearance is normal, the gemcitabine cisplatin would be better.
Sure.
So actually, according to NCCN guidelines, the dose dense MVAC is preferred.
Yeah.
And the second preferred is gemcitabine cisplatin. So based on the so then according to NCCN, it is dose dense MVAC which is preferred, sir, as compared to gemcitabine cisplatin.
Yes. Yeah. This is how you should answer. Both regimes are there. Okay.
Yes.
Both the combination are there, and these are the data. Somebody asked, how will you choose that?
Yes, it will be decided upon. First is the cardiac status. Now MVAC has this adriamycin. So if the cardiac status is not good, then we might not prefer adriamycin MVAC therapy. Also based on the creatinine clearance. So if the creatinine clearance is less than 30 ml per minute per meter square, then 1.73 meter square, then we will favor more in favor of dose dense MVAC.
Yeah. So based on the side effect profile,
30 is ineligible, boss.
Yes, sir. Yes, sir.
Less than 30 is ineligible.
So less than it should be more than 30. More than 30, sir. Sorry, sir. More than 30. Sorry.
So if you know the figure, then only tell. Otherwise,
Yes,
you
sir.
will be in trouble.
Yes, sir.
If you
Sorry,
don't know, then tell don't know.
yes, sir.
We people will.
Cisplatin eligibility works at creatinine clearance of 60 ml and above, and there are some adjustments which some medical oncologists make, and still use cisplatin at 50 ml per minute and above.
Okay.
Now, as per as your dose dense and MVAC, that is called the VESPER study. And the VESPER was a randomized study between GemCis and dose dense MVAC. And it was clearly, it showed the superiority of dose dense MVAC. In real world practice, people don't use it because clinicians don't want to pay so much attention to the side effects and treat them. Otherwise, it is a superior regime showing a superior absolute benefit than shown by an NACT with GemCis.
Yes. Whisper study. Studies the name.
Rajesh, can you mute yourself?
Vesper, VESPR, Vesper study.
Yeah. Okay. Yes.
All right.
Okay. So you have given therapy. When will you operate? And how will you proceed after giving chemotherapy?
So after chemotherapy, 4 cycles, I will reassess by doing a CT scan.
When?
Uh,
When?
Sir, at uh, so after 4 cycles, so each cycle of gemcitabine cisplatin is 21 days. So after 4 cycles, so at 3 months, sir, I would do a CT scan and assess.
So just the usual practice is when you start NAC, you do an interval response assessment at 2 months, just to keep a check that you are having some response and not progressive disease. Okay. You
Yes.
have a T3B patient. If you see suddenly at 4 months and find that the disease has progressed, that might be a problem. So interval response assessment is always at 2 months. Usually you will find these patients always come up with a CT scan done at 2 months additionally and after 4. Remember that.
Okay.
Rajesh, can you mute yourself? Dr. Rajesh? Yeah, thank you.
And secondly, cisplatin ineligible, the topic which you were saying repeatedly, cisplatin ineligible. Suppose if this patient is cisplatin ineligible, what options you have for NACT?
Sir, either we reduce the dose of cisplatin or we can use carboplatin along, gemcitabine carboplatin.
How you reduce the dose of cisplatin?
Sir, that I don't know, sir.
See, every one of you must have a straightforward knowledge. There is no dose reduction. When I said that 50 ml per minute creatinine clearance, they divide the dose of cisplatin and give it 7 days apart. So they don't reduce the dose. Okay. Secondly, without wasting everybody's time, cisplatin ineligible patients, there are some studies about neoadjuvant immunotherapy in which there is a partial complete response seen in with most IOs, durvalumab, atezolizumab, avelumab, and I think nivolumab, up to 30 to 40%. But they are very expensive and not used very clearly. So as far as studies are concerned, I said this because you should know it. And secondly, the cisplatin ineligible patient, carboplatin is never used, never. That is a practice in gynec oncology in ovary where they replace cisplatin with carboplatin, never in urology. Means somebody, even your examiner will fail you sometimes. The best option in those patients is you can go with an upfront surgery, if at all. Okay. Or you might use some measures to mitigate the renal function. I mean, you use some non-nephrotoxic drugs as antibiotics. Then you may sometimes, do a percutaneous nephrostomy to be, for relieving the kidney and expect a little better creatinine clearance. Otherwise, you have to go for a cystectomy. Come on.
Agree.
Right.
So the conclusion is, if neoadjuvant cisplatin based chemotherapy cannot be given, cystectomy alone is appropriate answer.
Yes, sir.
Or if there is an obstruction, then you can relieve the obstruction by doing PCN.
Yes.
And as far as GF concerned, if more than 60 standard dose, 50 to 60, what you are telling is 50 to 60 split dosing or extra hydration. These are the two ways. Less than 50 not eligible.
Yes.
What are the indication of neoadjuvant in T2 disease?
Neoadjuvant. Okay. For neoadjuvant given T2 disease, no? Yes, sir. So if the patient is not desirous of surgery, patient Then patient with that would be one. And the second would be mainly patient is not desirous surgery, sir. Mainly that is, yes, sir.
Any other indication?
Not fit for surgery and not desirous for surgery, sir.
Suppose T2 NX with extensive squamous features. T2 TIS with multifocal lymphovascular invasion. So in
In
such
that case,
case, new
we
adjuvant
can
chemotherapy.
offer new agent. Okay. Yes.
Okay.
So suppose that Ojas, this patient is not willing for cystectomy.
Then we would offer him, sir, first a neoadjuvant chemotherapy in the form of gemcitabine cisplatin, assessed at 2 months, as in reassess in the form of a CT scan, which would give the staging and what is happening, whether it has spread. Second would be reassessing the Karnofsky performance score of the patient and the creatinine and the GFR and the routine blood investigations, and then based on the current imaging, whether there is complete response, partial response, or no response, or and based on the current Karnofsky performance score, we will decide the further plan of management for the patient.
What plan of action after that?
Yes, sir.
What plan of action for the management?
So if it is completely responding and we have finished 4 cycles, and the patient has still a better Karnofsky performance score, then we can we can explain the patient that we should go ahead with the consolidation surgery in the form of radical cystectomy.
So
Radical
do you,
cystectomy with
do you think the patient who is not ready for surgery at present will be ready after 4 months after chemotherapy? And when you say chemotherapy, after chemotherapy, there is a complete response. Doctor sir, why do you want to remove my bladder? This is a complete response.
we have to explain the patient that the disease, though it is showing a complete response on as per the CT scan is concerned, but there are because it was muscle invasive in the first place, there are chances that it will recur again. So
So
as the yes, sir.
is asking bladder preservation in muscle invasive disease. So talk on that only. Don't tell here and there different things.
So remember, for everybody, remember, all students in at present today, if examiner asks if something other than standard treatment, that means he is asking about the other treatment options. Okay,
Yes, sir.
right? So if
Yes,
my simple question is that if patient is not ready for the surgery, so what treatment you will offer? That means the other treatment modalities. Okay.
yes, sir. So then, if this is not ready for surgery, then we can offer him, sir, sir, radiotherapy to the local area, sir. CTRT. So
Do you know
अरे
about
भाई
CTRT?
सेक्शन है तो R0 सेक्शन प्लस कीमोथेरेपी अल्टरनेटिव ट्रीटमेंट है नहीं है. ब्लैडर प्रिजर्व करना चाहते हैं, पेशेंट को सर्जरी नहीं चाहिए.
चलो बताओ TMT क्या होता है? अभी अभिषेक ने डाला है. अभिषेक has just put in the chat box.
sir, I don't know, sir. TMT.
So trimodal therapy or
Okay,
sandwich
okay.
therapy.
Primordial therapy.
Yeah.
Yes, sir.
Not a
देखो, patient who refuses, patient is not surgical candidate, patient is medically unfit. In such situation, TMT can be used.
Yes, sir.
So maximum turbidity, that is R0 resection with
Yes, sir.
महेंद्र सर और कुछ ऐड कर दो.
Yeah,
बख्शी सर.
you have to explain the patient that this is not at present a standard of care. Okay, though your patient doesn't want surgery, and you are opting for bladder preservation. Patient should be explained that this is not a standard of treatment, and after the radiation therapy, surgery becomes more difficult because of the plainness are become fibrosed and have more complication rates. Okay.
Yes. High risk of recurrence and high risk of mortality with this type of treatment.
Yes.
So that is the part of every counseling that patient should not regret after that if I have chosen that, so this should not happen like, okay. So you have to explain each and everything. Yeah, whatever treatment you are offering, any disease, whatever disease. Ganesh sir, you want to add something? Sir, unmute. क्या सर आप सर म्यूट थे?
नहीं, about tri-modality ना?
हाँ सर, हाँ, मतलब other than that we discuss. So maybe the dose only.
Everyone remember that there is one 2019 paper in BJUI about tetramodality also. So in those they had CTRT given patients in whom finally they had done a partial cystectomy at the site of the tumor and sent that for histopathology. And those who still had, very few had a residual tumor in whom they had consolidated with something like that. It's a Japanese author with a paper in BJUI. So just remember this term, tetramodality. So that is addition of trimodality, that is maximal TURBT, CTRT with a partial cystectomy. Okay. And one more thing, like in selected cases, actually in contemporary series, the survival, 5-year survival with radical cystectomy, that is the surgical versus CTRT arm, has been same. Carry on. I just said because these are some points which you should remember.
Okay, or just clear everybody. I think it should be the message is clear. Okay, about the bladder preservation. So
and
now,
secondly, when you talk about bladder preservation, somebody might ask you which are patients non-favorable for bladder preservation. So that category you should know.
Patient who is will not be able to for follow up. Patient with CIS. Then patient with the high risk variants, that is nested cell type, plasmacytoid, lymphocytoid variant.
Other things also, a tumor which is going little bit on the ureter, majorly trigonal tumor which is obstructing the ureters, because it will have dire complications of a dosed boost or a radiation. So these are not a very good patient. If I have a lateral wall tumor T2 N0M0 or sometimes a dome T2 N0M0, these are some favorable tumors for CTRT. Remember that. Okay. And in some type of patients, like the survival is equal. In the others, surgery is superior.
Yes.
So, Ganesh, is there any trial which shows survival benefit of doing the radical over this?
The trials में नहीं है, मतलब head to head नहीं है.
Okay.
But there are contemporary series of radical cystectomy and of CTRT. So दोनों का selected patient लिए तो match होता है सब कुछ.
Okay. Fine. So anything else you want to add into this?
So technically in the Western countries, they in such type of patients, they counsel them in the MDT about both surgery, radical cystoprostatectomy, and CTRT.
Yes, sir.
So one thing which you said in the beginning about urinary diversion and patient should be counseled about ileal conduit neobladder. Now, many times the patient asks, doctor, what do you say? So what would you say? Which diversion and why? Your patient is, you know the characteristics of the patient, this patient. I don't know, but you have seen the age, whatever.
So this patient has a good Canoffi performance score. He can take care of himself. Has a creatinine clearance which seems to be normal, and it was a high-grade tumor, but the the uh, the bladder, neck, and everything was normal, and there is no any CIS mentioned in this. So this patient could be offer a continent diversion, a neobladder.
Okay. So you would like to offer a neobladder. So what steps in the surgery you take so as to do a neobladder?
So we so the bladder
See, your
neck.
Viva exam is going to be for a limited time. So it's a direct question to you.
So we will send a urethral margin first to check for as it for frozen for whether it is positive or negative. Based on that, you can decide first.
So you send a specimen for a apex margin of the urethra.
Yes, sir.
Okay.
If it is positive, then the patient has to be preoperatory counsel that this would be done during the surgery.
Okay.
If the apex margin comes positive, then
So
it
it is
not
negative,
eligible.
no problem.
Then, sir, we will be assessing the bowel segment which has to be used, and
so bowel segment to be used, matlab, nowadays we do only ileal neobladders, right?
yes, sir. Yes, sir.
Then what will you assess in the ileum? Tell me.
So the length of the ileum,
See, now right from the beginning when you said your body language was more in favor of neobladder. Once your body language says that for the exam, then you should be like put about everything. Otherwise, then don't say neobladder. Then if you don't know things, nobody is going to give you extra marks for showing that body language of a neobladder.
yes, so we will say the length of the ileum,
Length of the ileum is constant in every human being.
we'll assess for the sir, this.
What will you assess? Okay, tell me one simple thing.
Yes, sir.
What is your thought on giving bowel preparation before cystectomy? And why?
So if you're planning for a neobladder, then a bowel preparation would be ideal, sir.
Why? Which study quote that?
I don't know the name of the study, sir.
Which literature, which year? If it is 1980, it is fine. Which study?
I don't know the study, sir.
Okay, simple thing. You are describing a bladder case. What is IRAS? You don't read only, that means.
So in IRAS doesn't favor for bowel preparation. So in
IRAS is not a human being like you and me. IRAS is a protocol.
Protocol, yes, sir.
Why do we use IRAS?
So for faster post-op recovery and mainly for faster post-op recovery.
So technically, using IRAS is one of the standards of care today.
Yes, sir.
Okay, then what is IRAS then?
So it means enhanced recovery after surgery. So preoperatively, intraoperative, and postoperative measures. Preoperatively, yes, sir.
So does IRAS say that ileal conduit don't give a bowel preparation and neobladder give a bowel preparation?
No, sir. Actually, ERAS doesn't
At
favor
least
in.
I didn't read any of the 10, 15
No, sir.
articles on ERAS saying that.
No, sir. It doesn't.
We'll
ERAS will
ask
not.
Dr. Mahendra. Dr. Mahendra,
Yes, sir.
your views on him.
Right, sir. Irash, actually, they should read Irash thoroughly.
Ojas, why do you feel neobladder also doesn't need bowel preparation?
And the reason behind
Nothing happened.
Yeah.
I think line is cut.
Irash has,
Using bowel preparation has been given up in most institutes now. There has been no difference in any kind of either bowel leaks or urinary leaks or anything. That is long gone. It's more about keeping the intestinal flora in place.
Yes, sir.
So about neobladder, how many types of neobladder you can do, or you know?
So it could be.
One of my teachers, Dr. Jagdish Kulkarni, used to always tell me when I was doing fellowship in Tata Memorial Hospital, you need to know 2-3 neobladders. Then you can be successful anytime in surgery. So which 3-4 neobladders you know?
So Hoffman, Kaufman, then the.
Kaufman कौन है?
नहीं, sorry.
एक तो स्टूडर है, दूसरा हॉटमन है.
Sorry, Hotman, Studer.
4-5 नाम बता सकता हूँ. ये देख किसी ने help किया. Abhishek Ghosh is very intelligent. He should only present a case.
There is Hotman, then there is Lee Bag, then there is Studer pouch, and this.
And Indian publications भी बोलो ना कुछ. Indian publications क्या है? एक राजीव गांधी कैंसर सेंटर ने लिखा है. They have presented the late effects, urodynamics, everything about that neobladder.
Indiana pouch is also there, but that is not Indian. Yeah, but Indiana pouch is there, and
Indiana pouch is a ileocecal continent diversion.
Yes, it is ileocecal. Yes, sir.
Your friend Amit has helped you. What is pitcher pot? So along with whatever you should know things there. So assessment of bowel cancer, some types of neobladder you need to read. Common neobladders you need to read. There are lengths of segments.
Yes, sir.
Along with Ojas, you have to be ready with questions like preoperative optimization of the patients in terms of his albumin level, BMI, weight, overweight hai to cessation of any smoking, since to up to how many weeks, then perioperative mechanical and pharmacological prophylaxis. तो मैकेनिकल का तो डिस्कस कर रहे हो, फॉर डीवीटी अगर है तो ये सब चीज एग्जाम में पूछते हैं.
Yes, sir.
These are the common questions asked in exam.
Yes.
And if you are planning for neobladder, अगर वो neobladder करके बाद में उसका continent है कि incontinent neobladder करने का सेल्फ कैलिब्रेशन कौन करेगा, वो एलिजिबल है कि नहीं, कंप्लायंट है कि नहीं, ये सब चीजें पहले प्रीऑपरेटिव असेसमेंट में बोलने के बाद में फिर neobladder जाना चाहिए.
Yes, sir.
अगर तुमने ऑलरेडी डिसाइड कर दिया neobladder तो फिर retrospectively whatever happen now, this will happen in exam also.
Yes, sir.
Okay.
Yeah.
So अभी क्या करोगे ओजस इस केस के? What will you do for this case?
So
NB is too complicated, huh?
Yes, so we will go ahead with an ideal conduit, sir. Radical cystoprostatectomy with ideal conduit with lymph node dissection.
तो क्या नुकसान था बोलता था तो उल्टा इजी हो जाता था ना.
Yes.
नहीं सर, then we would have asked you why not neobladder.
ठीक है ना, लेकिन एटलीस्ट एखादा एग्जामिनर हाईलाइट करके छोड़ भी सकता है.
Yes. So suppose that examiner ask why ideal conduit, so you can say that, sir, as I have not familiar with the neobladder and I have not seen my training neobladder, I would prefer this conduit, but I will explain the patient about neobladder. And if he wants neobladder, I have to refer him to a higher center or to the specialist. That is the straightforward and confident answer.
देखो एटलीस्ट प्राइवेट प्रैक्टिस में तुमको जो करना है करो, एग्जाम के लिए प्रिपरेशन शुड बी एस्केप मोड तुम्हारा ऑलवेज ऑन रहना चाहिए.
Yes.
And just Dr. Bakshi asked so many questions about the types of neobladder. The bowel segments are used for neobladder. Now commonly used, which are not used today. Okay. And their complication. Always remember, neobladder has a different complications than the other surgeries. Additionally, it has metabolic complications.
Yes, sir.
And you should know by each bowel segment, there are specific complications and the reason why is it so. Okay. It's all given in the Campbell.
Yes, sir.
Right?
Yes, sir.
Yeah. And I guess something about the reflexic or non-reflexic ureteral anastomosis. Any idea about that? Which is better? Pro and cons of both?
Yes, sir. So in case of refluxing anastomosis, the chances of urinary tract infection are more. Chances of UTI is more. Whereas in case of a non-refluxing, the stricture rate is seen to be higher.
But there are older series. What new series says that? New series says there is no difference actually.
Okay.
Okay, whether you do reflexing or non-reflexing, there's no differences on pyelonephritis and other complications, right? Okay, so you should also know about the types of the anastomosis, the name.
Yes, sir.
Okay, so
yes.
Okay, what are the I can say the
बोल दो,
principles?
names मालूम होंगे तो बोल दो.
Sir, in ureteroileal non-refluxing, the refluxing ones are wallets and breakers, whereas the non-refluxing ones are Lee bag and Lee duck, sir, Lee duck. This is for the ureteroileals.
We just keep quiet for 1 minute. Abhishek will type on the chat box.
अभिषेक ने आज ही हमारे साथ पूरा डिस्कस किया है. So Abhishek, if you want, Abhishek can just enumerate the full thing. Abhishek.
Yes, sir.
Yeah, just enumerate. Yeah.
So, sir, the ureteroenteric anastomosis can be divided into two, sir: ureterocolonic and uretero small bowel anastomosis. So, ureterocolonic anastomosis, sir, can be divided further into refluxing and non-refluxing, sir. Non-refluxing methods include Ledbetter and Clark, Pagano technique, Goodwin technique, and Strickler technique. And sir, the refluxing ones in ureterocolonic anastomosis include sir Nesbitt and Cordonniers. Whereas sir, the uretero small bowel anastomosis can be sir either end to end or end to side. That is one way of classifying them, and the other can be sir refluxing and non-refluxing. So sir, the non-refluxing refluxing ones include sir Bricker and Wallace, and the non-refluxing ones include sir Lee-Duke technique, sir the serosal dipping technique of Ghonim, sir the hammock technique, and the Griffith split nipple technique. Yes, sir.
Okay.
Yeah. So Ganesh, you want to just help them out and tell something what they should answer in exam in a simple way? Surgery or anything. When the question is asked, because they will not have so much of time, so they will have to enumerate just in like a couple of minutes or 3-4 minutes. So if you want to give some good guidance to them,
so
important point.
If anybody asks you about treatment, unless you know everything about what you are going to say, there is no point in saying this method or that method. You really need to be fast and confident, because the more questions probably you answer, you get more brownie points.
Right.
And maybe you can lead your examiner, but lead in the proper way. So talk something which you want them to ask you questions, but you should know the answers very clearly. And some basic protocols you should know, like NACT we discussed, like which patients are NACT ineligible and which patients are NACT eligible, but you might still do an upfront cystectomy. This is another category. Then steps of surgery, you should really know it in 8-10 sentences, the full cystectomy at least. What kind of lymph node dissection you are going to do.
Right.
Okay. Then
Correct.
reconstruction, in case you are not knowing much, it is safer to say ileal conduit, because now it has been proved with studies where the quality of life is almost similar at the end of, say, 2-3 years between neobladder as well as ileal conduit. So if you're not sure about neobladder, it's safer to say ileal conduit. And if you're sure about neobladder, go ahead with it, no problem. But then you should know. Again, about ERAS protocols is a very important thing. And you should really know, because it has been in vogue since the last 5-8 years now. And if you are not going to use it, then at least something modified ERAS has been used by everybody nowadays, in almost everybody. Like removing Riles tube early, giving patients liquids till the morning of surgery, sugary liquids, not giving bowel prep. These are standard things which are used. Not giving any gross pre-op antibiotics. This again, I think we have not proceeded beyond surgery, no?
Yeah.
So, common complications of surgery is the next question.
So complications could be defined as intraoperative complications, early post-op complications, and late post-op complication. Intraoperative complications would include bleeding, then injury to the surrounding organs, then this.
So bleeding, you said bleeding is commonly from where?
Could be from the superior vesical pedicle, or during lymph node dissection from the iliac vessels, or it could be from
but
the.
that is ekdam kg like. I don't think. If you say DVC or something, then still it is okay. But
dorsal
if you are
DVC,
going to
dorsal
bleed
vein
from the superior vesicle or the iliac vessels, then it is like you should not do surgery. Then you should give radiation.
So from the DVC, or from the dorsal vein complex, and from the inferior vesical pedicle.
So how do you manage dorsal vein complex?
Sir, we would take a figure of 8 suture at the DVC.
Okay.
And keep the thread long. And after completing the dissection, if required, we can take more consolidating sutures.
Okay. So some people also take one more suture ahead on the prostate near the bladder. Okay.
Yes, sir.
That is also what we standardly do. Secondly, if there is no space to take a DVC suture, what will you do? What options you have? There are many times a huge tumor. So there is no space only. There is no space to see what is the DVC. Even post-chemo, huge tumors many times. So what are other ways of managing DVC?
Sir,
No problem. Chalo. What is the percentage of all complications of cystectomy?
Percentages. So the early post-op complications,
all together.
Around 15 to 25%.
So 25%.
25%.
Roughly 25 to 28%. Cystectomy has a very high rate of complications from minor to major. Okay. And these are in the best known centers and high volume centers.
Yes, sir.
Okay. Sir, itna hi hai matlab, that's it.
Okay, so Ganesh, next time now the last one is left, that is the metastatic. Can
Bladder.
you get someone from Tata to talk about chemotherapy and radiotherapy? Is it possible? Because this is what we have not covered, along with with your views, your all this data in metastatic, we have not covered chemotherapy and radiotherapy. Because the next patient what we are going to present has got combination of all these things.
Okay.
So in that case, to be very frank, we have done it was a muscle invasive non-metastatic. We did a radical cystectomy. He was doing well, then he developed metastasis and lots of complications. So that is what I am saying. You have got 7 days. If you can arrange someone from Tata.
We'll talk, sir. No problem. Mahendra is there or
Okay.
Mahendra is left?
Yes, sir, I have here.
Mahendra?
Mahendra, वो प्रिया तो
Mahendra?
बात कर सकती है.
Sir, Priya, हाँ.
प्रिया बाहर गई है.
No, she's going on 19th. I'll ask her tomorrow.
And वो अमित जोशी को भी request कर सकते हैं. Amit likes to teach anyways.
ठीक है. I'll talk to them, both of them tomorrow.
Yeah. So next time we finish that metastatic also. So that is over. And I think by Thursday they are going to get their result. So within, I think 1.5 months. So we have now 2 or 3 weeks in Tuesdays with us. So we'll ask them what else they want after
No problem. Whatever
Tuesdays.
they want. Otherwise, we'll not waste their time.
No, but
Ganesh-
this is, I think this is the best thing. They will love to have chemo. No one has taught them about chemotherapy and radiotherapy
But
in the case presentation.
All here today, majorly out of the 29 are exam going.
Yes, sir.
I think so.
But then
Ganesh
one
sir.
advice to you, start presenting to each other also, because you should learn to talk to the examiner. See, on examiner side, they may not know
I am
anything, but they can
requesting,
ask you
Ganesh,
100
I am
questions.
requesting all of them. Only 4 or 5 of them are presenting. If they present on this platform also, no, it is very good.
Sir, there is an inherent fear that मैं present करके ठीक नहीं हुआ तो क्या होगा. So
Sir,
I'll tell you, you present to each other at least.
सर यहाँ कुछ भी प्रॉब्लम नहीं है. This platform was made to do a mistakes only.
Correct.
We
Yes,
have
sir.
been telling them, Ganesh bhai, last time also, Gite sir, myself, Gaurang sir, we told them, please present.
They should come
Make
forward
mistakes.
and try to present the cases without fear. इधर कुछ भी गलती हो गई तो कोई प्रॉब्लम नहीं होने वाला. यहाँ कोई
Correct.
मार्क्स नहीं है, कोई पास फेल नहीं है, और कोई डांटने वाला भी नहीं.
Correct.
Yes.
Sir, few words about retained urethra. Ganesh sir.
कौन सा सर सुना नहीं, सॉरी, किसके बारे में?
Post surgery retained urethra management.
Okay. So it depends on the histopathology sometimes. If you want to do a urethrectomy, or if there is a presence of some urethral tumor, your prostate is invaded by the bladder urothelial, and it involves the stroma of the prostate. So these are some cases where we should do a urethrectomy. We can do it at the same time also, or if we know it in advance, or we can do an interval urethrectomy, which can be done maybe after, say, 3 months later. And it is a perineal incision. Some people take only midline, some people take a lambda as usual. And you can dissect and invert the whole urethra, even from the penile bulb, right up to the external meatus. After doing surgery, achieve adequate hemostasis, give a nice compression dressing. That's it. And if you, in cases where we don't need to do a urethrectomy and an ileal conduit is done, most importantly, mostly we forget in follow-up. Technically, urethral washings are also important, along with that urine cytology from the fresh urine in the conduit. That much you remember. I had asked a question to Ojas about management of DVC. So what he answered was right. That is how you manage DVC. In places where you can't have space or whatever problems, we can potentially use dual energy, bipolar energy, and try what happens with the DVC. So you can either use a handpiece or you can use a lap wala instrument with bipolar energy, or worse circumstances, which I have done sometimes, just cut off with the scissors, let it bleed very momentarily, and just take a suture. But you should be really fast in all that so that the blood loss is hardly 50-100 ml.
Okay.
Now, only one question: when we are doing bladder preservation, there are 25% chances that prostate may be involved with the bladder. So, do we have to do evaluation for CA prostate also when we are doing bladder preservation?
No, sir. Matlab, prostate has been involved in various series from 18 to 25%, and that is involved in the sense CA prostate, na?
Yeah.
CA prostate, but it has been always found in all these series that the prostate cancer found along with bladder cancer has been actually a early prostate cancer or a very low risk prostate cancer.
Okay.
So you will never find a 3+4 Gleason score also. You will always find 3+3. So these are all incidental. In case sometime somebody has done a PSA and you know that it is prostate cancer proper along with bladder cancer, those are the few cases where you find a little upgraded prostate cancer.
Okay.
Sir, few lines about adjuvant chemotherapy.
So basically, adjuvant chemotherapy regimes are same as that of neoadjuvant. The trials are also the same. Meta-analysis is there, advanced bladder cancer meta-analysis, and it also shows 5% absolute benefit. That I think one sentence only you all should remember with adjuvant. So important thing is when to give adjuvant. So usually when you are given neoadjuvant and the YPT comes good, then you don't give adjuvant. Sometimes if we get a tumor even after neoadjuvant, then we give, probably I've seen my medical oncologist giving 2 cycles of adjuvant. If you have not used neoadjuvant, then you give proper 4 cycles of adjuvant chemotherapy, which again can be Gemcis, which is used in real world, or it can be DDMVAC again. And adjuvant may again, the medical oncologist also believe that here carboplatin can be given. So if creatinine clearance is low, you can use gem carbo.
Okay.
Again, there is नहीं अपन advanced का किसी को बोलेंगे ये करने को. We'll tell somebody.
Yeah. Yeah, that's what I'm saying. So next time, that is what I'm saying. If they give the good insight of all the chemotherapy and the
I think
total.
महेंद्र को बोलते लेने को. Lymph node dissection के बारे में कुछ बोल दो महेंद्र.
So let us know how much Ojas knows about peritoneal dissection in
Ojas, you tell how much
Mahendra, it is better that you say. It is better that you say, so that we finish in time, and they when they listen to this talk, it will be very easy for them.
Okay. So about PLND in bladder cancer, there are 4 types of PLND. They are limited, standard, extended, and super extended. Okay. So I'll not go so deep about the boundaries and other things. So what guideline says, we have to perform extended PLND always. Okay. And in patient who are having common iliac node, those cases we should do a super extended, that to the inframesenteric artery. Right. So this is the only which I wanted to 2-3 lines. So you should always perform extended PLND, not a standard or not limited.
Okay. Out of limited and extended was better in the studies.
Better. Yeah.
Out of comparison between extended and super extended, again, it did not show any difference between the two. So extended was okay.
Okay, so never compromise with the PLND. You always have to do PLND bilateral, whether it is a right side tumor or left side tumor. Okay.
Fine.
Minimum nodes to be removed, sir.
Ojas, any idea?
So 12. 12.
It is, I think 15, 16, 16 around 16 or 19. I think some studies got 19, some study go 16.
Old books, it is more than 12, but currently I don't know.
Yeah. So anyway, if you remove all these pockets, you will get minimal these notes collectively from right and left side. There is a no study which quote that right side this much node, left side this much. It's a collectively total nodal mass removal.
Okay.
Yeah. Gaurang sir, can we
Yeah.
plan one small talk about bladder preservation on next talk? So about the
So let us
instead of
So it
having
is
let us do that way. One of the student will talk on that. Okay. We'll just present that case in 10 minutes, and after that, just little question answer, chemotherapy, radiotherapy, and bladder preservation.
So sir,
Is that okay?
सर अगर हम इसी केस को we can take as a patient opted for budget preservation, and after that can go with the indications, contraindication, and the how we do bladder preservation. That talk for a fundamental ka talk, and the other case we can discuss for 15 minutes, and then again talk 20 minutes about the chemotherapy.
Okay. If you got any case, just let me know in this couple of days.
Or sir, already you have na metastatic this thing bladder cancer.
Yeah. No, if you have done any, they will just present in 5 minutes and we can go ahead.
So I will ask Swami Joshi sir if he has some case 1 week.
Okay.
I'll ask him, sir.
Sure. Okay. Fine then. Huh?
Okay. ठीक sir.
Okay.
Yeah.
Bye.
Good night.
Thank you.
Thank you, sir.
Good night.
Sir.
Good
Thank
night.
you, sir.
Hey, Ganesh
Thank you,
sir.
sir.
Bye. हिरेन भाई
Good night,
बड़े शांत है हिरेन भाई आज.
अरे आप लोग
Bharat
बोल
sir,
रहे हो तो फिर
please.
हम क्या बोलेंगे?
अरे
हिरेन
सरकार.
सर आज दिन भर काम करके थके वाले लग रहा है.
नहीं सर. Okay, sir.
Okay, sir. Good night. Good night,
Good
everybody.
night.
Good night.
Good night.
Goodness.
Bharat sir.
Yeah. Hello.
Actually, sir, by mistake, actually, sir, due to network error, you are a host. I have to end the session because तो ये recording sir चलते रहेगा रात भर. So please make me host so that I can end the session. Or you can end the
I
session.
made
sir.
you host. I made you host. किसको बनाना है
Okay.
host?
राकेश यादव.
Okay, sir. Good. No. So now, sorry, now Dr. Paras is host. Sorry.
Yes, sir.
So
Yes,
sorry.
sir. Yes.
Okay.
Thank you, sir. Thank you.
Okay.